Okay, it's 2 o'clock. We'll begin with our opening slide. Today, we welcome you to the first of 2 of our 2016 SiNERGe CBO Collaborative webinar series, focusing on the very important issue of transitioning from adolescent to adult care. My name is Grace Bigelow, and I am the CBO Outreach Coordinator and will be moderating today's session. With these presentations, we are hoping to provide the most current information on topics of particular interest to the sickle cell community. We hope to target a lay audience, having the content be very accessible to all: patients, family members, caregivers, and the wider sickle cell community. Of course, we always welcome suggestions from all of you on topics that you would like to learn about or people you'd particularly like to hear from. We're excited to continue with our 2016 webinar series. We'll continue in the theme of living well with sickle cell, focusing today and in our August session on transitioning from adolescent to adult care. We are calling the series A Smooth Transition from Adolescent to Adult Care, Sickle Cell Disease Care, Eliminating Barriers, Enhancing Resources, and this is part 1. We are very privileged today to have the highly esteemed Drs. Vicki Tepper and Jane Hankins presenting. Next slide, please. On the first on general issues and concerns during this crucial transition period, and then focusing more specifically on transition with sickle cell disease. Dr. Hankins will discuss her program at St. Jude, which has been in place for the last 6 years with significant measurable success. We hope their presentations will both inform and inspire us, hopefully galvanizing us all in our resolve to continue working towards improving the lives of those with sickle cell disease, as well as improving the relationship between those living with sickle cell, their families, and the healthcare system. These presentations will be followed by a hopefully robust question and answer period as time allows. We ask that you submit your questions in writing on your computer screen, and I will read as many questions as we have time for the presenters for their response. And now it is my pleasure to introduce our first speaker, Dr. Tepper. Dr. Tepper received her PhD in clinical psychology from Vanderbilt University. She is an associate professor of pediatrics at the University of Maryland School of Medicine. She currently serves as the division head of the Division of Pediatric Immunology, Rheumatology, and Young Adult and Adolescent Community Health Services Program. This program is recognized locally, nationally, and internationally for providing comprehensive one-stop care for HIV-infected pregnant women and their infants, as well as specialty care for HIV-infected infants, children, youth, and young adults. Dr. Tepper has been the principal investigator of grants examining issues related to medication adherence and psychosocial adjustment of children living with HIV in the United States and in developing countries. She has numerous peer-reviewed publications and has been invited to present her findings at national and international meetings. She is spearheading a program to support adolescents with chronic illness and their families in the transition of pediatric to adult medical care. Welcome, Dr. Tepper.
Thank you, Grace, and thank you very much for inviting me. Next slide. Okay. What I was going to speak about today is really to present sort of an overview of how transition is thought about and how, as clinicians, we should be thinking as we're developing programs to address the needs of young people with chronic illness, and in this case, sickle cell disease, in the transition from pediatric to adult care. And since most of our work in the transition process starts during the adolescent period, I felt that it was important for us to have this sort of backbone to the presentation around adolescent development and sort of understanding the challenges of being an adolescent before we then lay on top of that the issues of living with a chronic illness and then the transition. So next slide. So I'm sure all of you know that it's really important to remember that adolescence is not only an emotional, psychosocial period of time, but it's also a developmental stage for young people. And research that's been done in the last couple of years using fMRI has enabled us to understand more about the brains of young people and understanding sort of the trajectory of development for adolescents. What we've learned from fMRI research is that the prefrontal cortex, that green part on the slide, is really still developing until about the age of 25. So that when we're talking about developing these skills to prepare kids, young people for transition, we're talking to people whose brains might not be fully ready to do that. Because that prefrontal cortex is really responsible for almost all of the skills that young people need to prepare for transition, such as planning and organization, prioritizing and perseverance. And for those of us who work in medical settings, you know that perseverance is the key to success. The attention and impulse control is found in the prefrontal cortex, as well as self-monitoring, problem solving, critical thinking, and judgment and learning from experience. So if you think about preparing an adolescent for the transition, basically everything that's going on in the prefrontal cortex is part of what's needed in order to be successful at transition. And I always like to point out that it's kind of interesting how we've structured the world around adolescence, because at 16 in Maryland, you can operate a car. At 18, you can vote, you can serve in the military, and at 21, you can drink alcohol. The only organized structure for which age 25 is the cutoff is really just renting cars. And so it's sort of interesting that we're asking young people to take control of their health care at a time when they might not really have all the sort of mechanics in their brain ready to sort of do that, and only the people who are, you know, renting out large pieces of equipment for young people to drive have sort of thought about the fact that 25-year-olds are really more prepared. So within that context, though, we still work with adolescents because there's a great deal of variability in when these skills are available for young people. So can I see the next slide? And so we're going to think about development now in terms of where young people's brains are, as well as what are the sort of psychosocial, emotional kind of stages of development. So next slide. So the tasks of development that are sort of experienced by adolescents sort of happen in a progression. They don't happen in a sort of solid line. It's kind of a very wavy line. So sometimes we reach certain stages much faster than others. But these are the kind of tasks that adolescents face. One is autonomy and normality. Adolescents like, you know, to be like their peers. They want to fit in with their peers. They want to be accepted by their peers, and they want to have more independence. And that's sort of developmental trajectory of that, is that we want young people to start testing those skills out over their adolescence, so that when they reach adulthood, that they have achieved, you know, some degree of independence and are able to be self-sufficient. During adolescence, the development of self-esteem is really continuing, which includes body image, the formation of identity. A really critical component to adolescence is the formation, is peer acceptance, like fitting in with your peers, and really being able to establish meaningful and fulfilling social and peer relationships. So those are the things that all adolescents go through all around the world. There's not like a specific sequence in which any of those are happening. They're happening sort of all at the same time, and they're challenges that adolescents continue to face even during young adulthood. Next slide. However, for young people who are living with a chronic illness, these developmental tasks take on a whole different level of stress. For example, autonomy and normality is what we just talked about in terms of what adolescents are striving for, and they're striving to be independent. However, they still need supervision for adherence to care for health-related issues in a different way than their peers who do not have a chronic illness. For young people, body image is such an important component of how they see themselves and how they're viewed by their peers. But if your chronic illness impacts your growth and development, that certainly would be a challenge. One of the things that the young people that I work with talk about a lot is wanting to fit in when they feel very different, and living with a chronic illness, whether it's sickle cell disease or HIV or diabetes. They know they're not the same as their peers who are not living with a chronic illness. And so trying to fit in when there's things about themselves, even if they don't share them with others, that they know that they're different, and that makes it more challenging. Next slide. Another thing that I think is truly important, especially working with young people with chronic illness, is the development of their identity within the context of living with a chronic illness. And more than one young person has talked to me, irrespective of the chronic illness, is that they're more than just their disease. So young people with diabetes do not like being called diabetics because they're not just diabetic, they're people, and they're people who have diabetes. And this is true for young people who have sickle cell disease. And so trying to figure out who they are at the same time as understanding and coping with this other identity as a person who's living with a chronic illness is another challenge. Peer acceptance, as I mentioned earlier, was really important, and many young people are afraid that if people knew about a chronic illness, sickle cell disease or other, that they might be rejected by their peers because of misinformation or mythology about what their illness is or how it might impact them or their social relationships. And finally, since the whole sort of driving force of adolescence for many adolescents is the establishment of meaning and fulfilling social and peer relationships, there's a great deal of concern or worry that if they were to disclose their health status or having challenges where they're in the hospital and out, how will that affect their ability to have social and peer relationships, and will anybody love them? So if you're thinking about the adolescent, this is sort of their life at the time when we're now going to be bringing up the fact that you're going to be dealing with all of these things. And also, we're going to talk about transitioning from the safe place that you are to a new place that you don't know about. So next slide. So as I said, the interaction of this developmental stage and transition is important because we have adolescents who are living with their chronic illness, working through these issues of dependence, for healthcare management, the tasks of adolescence, and now we're saying in addition to dealing with all of that developmentally, you're going to also have to think about separation from not only your family, your nuclear family or the family that you live with, but also the second family or the healthcare team. So that's the additional overlay that's important when thinking about transition. Next slide. So when we think about transition, we're thinking about a multi-stepped planned process, and we should be thinking about it from a gradual and developmentally appropriate sort of approach. And it's obviously going to be collaborative both with the adolescent and their family. And we're thinking about it being holistic and attending to the medical, psychosocial, educational, and vocational needs of adolescents as they move from child to adult-centered care. Next slide, please. So then why is that so hard? It sounds like, we make transitions all the time. Young people start out in elementary school, they transition to middle school, many times people move and they transition to new neighborhoods. So transitions are part of our lives. But for young people with chronic illnesses and their families, they really form an uncommon bond with their healthcare team, especially with the specialists who have been instrumental in their diagnosis and the treatment of their care. So the separation there is not the same for them. Even though the same skills might be involved, it's really quite different because of this intense relationship that the healthcare team has formed. Next slide. And also because the cultures of pediatrics and adult medical settings are quite different. And I just put this little cartoon in there because I think it sort of made me laugh. It's sort of like when you don't really know what exactly is involved in the transition, things can go terribly wrong. So inadvertently, Roy dooms the entire Earth to annihilation when, in an attempt to be friendly, he seizes their leader by the head and shakes vigorously. I just thought that if we don't do our transitions well, things can go really poorly for young people. And the culture that we're going to talk about in terms of the transition is the huge part of what could go very badly. So next slide, please. So first we start out with our young people in the pediatric setting. And pediatric settings are known to be much more established multidisciplinary models. They offer a high level of psychosocial support. By definition, pediatrics is developmentally oriented. Again, because families are directing care for young children, it's family-centered. Those of us in pediatrics often like to think of ourselves as warm and optimistic and interpersonally oriented. In a pediatric clinic, it's often more informal and relaxed, and it's very important that parents are really involved in helping with the care and providing consent. So that's what pediatrics kind of looks like. Next slide. In the adult clinic, it's quite different. So while in the pediatric clinic, when my patients come in, And the front desk person knows that's the end of school year. They talk about, how did your classes go? Did you go on a field trip? When I go to my healthcare provider, no one's asking me about, how's the end of my budget year going, because they know at the end of June, it's the fiscal year's ending and I might be thinking about that. So there's a lot less psychosocial involvement by the staff. And in fact, the settings are often more businesslike or formal and perceived to be judgmental by patients, because in pediatrics, if you miss your appointment, we might, call you and chase you down and encourage you to come back. In the adult clinic, if you don't show up, there's more of a judgment about why didn't you come, and it's a more negative experience. In adult clinics, it's much more patient-centered rather than family clinic-centered, and the focus is much more on the disease process and less on the more holistic, what are you doing in school, what's happening, with after-school activities. Clinic visits tend to be procedure and lab-based, and most importantly, our patients are required to be autonomous and function independently. Next slide. So there's a conflict of cultures here, because my colleagues in the adult clinic believe that we baby our patients, and my pediatric colleagues believe that we're worried that our adult providers are not going to care enough about those kids that we've been taking care of for the past 15 or 20 years. Next slide. In addition, we have concerns coming from all different groups. So the patient is concerned, are they ready to grow up? Will the adult providers understand them? They describe feeling dumped or abandoned and tossed into the adult milieu. They're leaving behind their medical team, who's really like an extended family. And if they have a health concern after their 18th birthday, if they haven't transitioned, all of a sudden they're finding themselves being admitted to adult services and in the adult EDs rather than on the pediatric side. Next slide. Parents report being concerned about whether their adolescent will receive the same kind of care. Will the adult provider include the parent in the same way that the pediatric providers did in the treatment planning? And will the adult team have the same knowledge that the pediatric team has demonstrated to them over the years? Next slide. Healthcare providers, sometimes on the pediatric side, will admit to having difficulty letting go of our patients because we're worried about, our patients and how we've taken care of them. Who will do the follow-up? And honestly, how do you manage the boundaries in terms of where your care ends and the new provider's care begins? Next slide. So when we start to think about transition, and we're going to get into this a lot more in just a few moments, but just some highlights. In general, we want to assess readiness for transition, and it's very important to think developmentally rather than chronologically. It's important to think about health status. We're less likely to want to transition someone who's medically unstable at the time, so we hope to catch them during a period of more stable health. We also want to think about co-occurring life transitions before we think about transition. Have they experienced other recent losses? Is the young person also leaving for college? For young women, are they pregnant? Because there might be times when transition would be more easily facilitated or be more of a challenge.
Hi, Dr. Waite.
Next slide.
Good.
So when to actively address transition? The literature has a great deal of diversity here. Some people believe at the first diagnosis or initial visit, you start to talk about the fact that our practice takes care of young people up until this age, and at X age, our policy is that we start to prepare for the transition, which will happen at this time. It should also maybe be discussed at every well-child visit as part of growth and development, part of anticipatory guidance. Some people believe that the first time transition should really be discussed is at puberty, because you can talk about the person's body is changing, other things are changing, and so this would be a good time to think about transition. Other people feel that at age 16, for kids who have an IEP, because transition is included in their school IEP, and that might be the time to transition. Next slide. Again, at 17, for patients who are going to require guardianship and families role and having a family role in their ongoing medical decision making, that's the time to do it. Some people have thought and have operationalized 2 years before there's a change in insurance coverage. So with changes in insurance now, young people can stay on their parents' health insurance until they're 26. So some people are looking at just before that happens, or just in general 2 years before whatever the anticipated transition is. There's not one right answer to this, and it's really a program by program decision to make. And I think that Dr. Hankins is going to talk about using different tools to think about the assessment of readiness in terms of sickle cell disease. Next slide. And she will pick it up right there. So thank you.
Thank you so much, Dr. Tepper. We're going to move on now to Dr. Hankins, and I again have the pleasure of introducing our next speaker, Dr. Jane Hankins. Dr. Hankins is an associate member of the Department of Hematology with more than 15 years of experience caring for children with sickle cell disease and considerable experience in leading and conducting translational and clinical trials in this field. Her work in studying the role of hydroxyurea in sickle cell disease has been significant in demonstrating the safety in infants, its role in organ protection and reduction of mortality among children. In addition, she and her group were the first to show the role of mobile health, text messaging, in improving adherence in sickle cell disease. She has been PI or co-investigator on several federally funded grants, NIH and HRSA, aiming at advancing the care of sickle cell patients, including testing new therapies and designing new systems of care for this population. She has conducted phase 1, phase 2, and translational studies and was co-PI on an NHLBI-funded international phase 3 clinical trial in sickle cell disease. She has successfully participated in multiple federally funded multi-center studies as a collaborative site. Her work in promoting improved transition from pediatric to adult care has resulted in significant reductions in healthcare utilization and successful placement of young adults in medical homes in Memphis. Welcome, Dr. Hankins.
Thank you, Grace. Thank you, everybody. It's been a pleasure to join this session today. Thanks for the invitation. So I'm going to talk about the transition to adult care for patients with sickle cell disease. And Dr. Tepper's talk was the perfect companion to my talk because it really introduced the subject, and now I can delve deeply into this problem in the sickle cell population. So next slide, please. So these are my disclosures, funding. Next slide, please. So the first thing to keep in mind is that as with many chronic diseases in the United States, in Europe, and many emerging economies in the world, what we're observing is that children are surviving into adulthood. Sickle cell disease is not different than that. And what this graph shows is that in the 70s, which is marked by this rectangle, that in the 70s, children would still die a lot, mostly from infection, and that's no longer the case in the 2000s. And on the red curve, you see data that is most recent from 2 years ago, 2014, that shows the mortality among children is very low. And then if you click the button, you will see that this rectangle moves to the right to show that the mortality now has shifted to the right. If you look at the 70s and just 2 years ago, that the patients, they start dying now a little bit later than 30 years ago, but they still die in significant amounts, especially when they are young adults. So from adolescent to young adults is when you see the spike in the mortality, and that unfortunately has not changed in the last 30 to 40 years. So that tells us that yes, a lot of children are becoming adults, and unfortunately a lot of our adults are dying a lot around the time of transition from pediatric to adult care. So the next slide. This slide shows that not only they are dying, but they are utilizing the healthcare system in an incorrect way. So when they are young adults, which is exactly the time when they go from pediatric to adult care, they're trying to establish medical homes as adults. They're having tremendous difficulty of establishing care, and as a result of that, they end up in the emergency department and they're admitted to the hospital more frequently. So if you see, if you click on the animation, if I am to pick out what is the age group in which they utilize the medical system the most, is exactly between the ages of 18 and 30, when they leave adult care and go to, and they leave pediatric care and go to adult care. And that's more than any other age group in the sickle cell population. Next slide. And Dr. Tapper very beautifully listed all the barriers to transition among the adolescents, all the concerns of the adolescents in becoming adults. So we can just briefly go over what the adolescents do, which is no different than the other chronic diseases. So this just validates, you can just click to show all the bullet points, but this just validates that people with sickle cell disease are facing the same problems that all the other chronic diseases in the other chronic diseases in the United States. And if you so fear to move from pediatric to adult care. And when you look at the programs, Dr. Amy Saboda from Boston has very nicely published on this issue that she showed. A lot of the programs in the United States are, until a few years ago, they were not really implementing all the necessary steps to ensure that the patients were transitioning adequately from pediatric to adult care. So for example, a lot of the programs were keeping the patients much past the age of adulthood, which is legal age of 18. So if you keep clicking, a lot of the programs not only kept the patients, but also the other problem was hard to identify adult hematologists that took care of these patients. So collectively, the most significant barrier that was identified was that it was a lack of providers to see these patients. That coupled with the lack of preparedness of the adolescents to go. And on the next slide is the barriers now seen from the adult standpoint. So for those who have crossed the line and now they are in the adult care, what do they view as significant barriers for them to get established and navigate the adult system? So now there are additional problems such as employment. A lot of patients are having difficulty finding jobs, insurance coverage. A lot of them lose coverage as they go from pediatric to adult care. Relationships play a major role. Now your parents may not be involved anymore. And now you sometimes you lose that support system that you had as a child. So just compounds the problem of the difficulties in transitioning. So on the next slide, if I were to summarize all the barriers, both for adolescents and for young adults, so you can click on all the bullet points. So insurance coverage, and you can read lack of adult providers, lack of comprehensive programs. There's a lot of misconceptions. So the patient sees pain treatment in one way, and the provider seeing a different way, right? And the unpreparedness of the adolescents. So on the next slide is we've been working with on this problem for the past 6 years and have been very concerned because our adolescents were not graduating from our program and successfully finding medical homes. They sometimes were referred to an adult program, but they abandoned care. They weren't ready to be there. So start really thinking about this problem and start developing our transition to adult care program. The next slide. So what we used as a framework when we start thinking about what did we need to put in place to ensure that patients were transitioning we looked around in the literature, and the American Academy of Pediatrics and other societies actually had published on the subject and actually had some guidelines and some directions that we took. But one place that came as we were planning the program were the 6 core elements of transition. There is available on the website, thattransition.org. And this was very helpful because it really laid out all the steps that should be in place according to the patient's age and the stage on the transition. So this is just an excerpt from the table that you can find on this website. And if you click on the next button, on the far right is an update of this framework for transition that all it says is if you're going from pediatric to adult care, you don't necessarily need to leave your where you're being treated. So the first column is if you're on the pediatric side, what should you do? If you're on the adult side, what should you do? But if your patients are not actually physically moving, what should you change about the way you take care of your patients so the patients receive adult care in a pediatric setting, or you may be a family practice, so you just have to treat the patients as adults. In the next slide, so I try to simplify the 6 core elements of transition. So the 6, and I simplified here by saying that the first thing that needs to happen is that, as Dr. Tapper said, you have to let the patients know when they're going. So we began our program of transition to adult care at 12, and we have a transition policy that we give them, and then we track and follow them. We create a registry, which most recently became a research study, cohort study, but that's how we track the progress of our patients, how many patients we have, where they are in the process of planning and learning and getting ready to transition. And then we measure readiness along the way. One thing I have to say specifically for sickle cell disease, there's not one single measure that is specific for sickle cell disease. We adopt measures from other diseases or generic measures. The clinical trial, the guttransition.org has a very good measure that I'm going to show next. Then you have to have concrete planning, right? So we have to really show the patients what are the steps and what should you know as you go. And then you transfer the patients, but you have to help them. You have to make the appointment, send the records, and then you have to close the loop. Then you have to ensure that the patient did make it. So 3 to 6 months later, you have to be able to say, okay, my patient did make it to adult care and he's still there. So the next slide is the map of our program. So in this timeline, we have activities that go from 12 to 25, and every 6 months we measure certain things at readiness, or we educate the patients about what they should know as they go from pediatric to adult care. So this is just what we developed and we thought were important steps that had to happen in a developmentally adequate manner from 12 to 25. So several activities that we have in place. And to do that, we need a multidisciplinary team. So we have a social worker, 2 psychologists, we have nurse practitioner, nurse coordinators. So we really need a team to have this in place to really be able to provide the patients with all the tools that they need to transition. So the next slide is how we do that on a day-to-day basis. How do we operationalize? So everything you saw on the map of our program, we have as what we call the plan of care in our clinic. And in fact, the transition to adult care program is a natural progression of our care, our regular clinical care that begins at birth. So we have a plan of care from birth to 25. Every 6 months we have a table that looks like this, that just makes it very simple for each provider in clinic to know what they're supposed to do at which age. On the next slide shows the plan of care that is specific for a teenager between the ages of 13 and 14. So the things that are listed here are the things that were on a map. So it just makes it easy for us to know we have the map, and then this is what we have to guide us in clinic, what we have to do. And this links to our EMRs, our electronic medical records. So every row that you see here is an order in our EMR. We use SiNERGe. So that's how we operationalize on a day-to-day basis. So next slide. Our program is emphasizes very heavily education. So we pay a lot of attention to health literacy, how much they know about the disease. not only that, and how much they know about their own disease, so our health, their personal medical history, and we also provide genetic counseling clinic to the adolescents. And the next slide. This is just an example on the left, the material that we developed. And with every educational material that we develop, that we use in clinic, we measure gained knowledge. We find this very important because we don't want to introduce elements to the transition program if we're not measuring and showing that they are successful. If they're not successful, we drop them. If they're successful, we keep them. So we have a pre and post test that we give the nurse coordinators are actually the ones who do this questionnaire and the education in clinic. So we measure before and after how much they learn. And then we keep that because if we want to, publish and have research linked to the care that we provide in clinic, then we save those scores for future work. Next slide. And then measuring transition readiness, as Dr. Tapper mentioned. The next slide. There's no specific measure for sickle cell disease, but on the next slide, you can see the things that, oh, I'm sorry, these are just why we need to measure transition, right? I agree, Dr. Tapper, that using the chronological age, some programs use 18, some programs use 21, is not really the best measure. So we really need to be specific about the domains that we think that the patients should have mastered before they go to adult care. We use these 4 domains: if psychosocial, emotional, vocational, and medical domain. That's what we use to develop our own measure here, that we are still testing the predictive validity of our measure. But on the next slide is a measure that was developed and published on that website, gottransition.org, and it was modified by members of the American Society of Hematology to be customized to sickle cell disease. So this is a measure that has been endorsed by the American Society of Hematology. It was not initially developed specifically for sickle cell disease. It was just customized to serve the purpose of a person with sickle cell disease. So that's one measure that can be used in clinic multiple times along the way. So we can use at 12, 15, and 18. You can use and then track the scores over time. Next slide. And then the middle of the road, right? So then you prepare the patient and then it's getting close to the time that you think the patient is ready to go. So what we do in our program, we introduce the adult providers by taking them on a tour of the available programs for adults in Memphis. We call this the transition tour program. We do that 4 times a year, and that's for patients at the age of 17 and their parents. We take them to the providers in town on the St. Jude bus and then come back, and then we have lunch, and then we discuss what the providers, how do they like their providers, and then we ask at the following visit where they would like to go. So we have 2 more visits after this tour happens. And on the next slide are our results. So we went back and looked at the first few years of this program to see what the program was doing to our patients. And sure enough, the patients who chose to participate on the program were more likely to attend a first visit with the adult provider and remain with this adult provider a year later. So we consider our tour in the satisfaction survey that we apply at every visit, every transition tour event is very positive. So the patients like, the families like, they feel more comfortable knowing who the providers are and choosing, and their appointment rate is higher, fulfillment with the adults. So we kept this in our program. Next slide. So then one issue that is important is as a program, not only on a personal level, but as a program, how do you judge that your program as a whole is successful? And on a personal level, how do you decide that the patient's successful transition to adult care? On the next slide, so the answer is really we don't know. There's no definition that is accepted by the field that is a successful transition to adult care, and I think that's true for other chronic diseases. But this is an interesting publication that they thought about it, and they published what they thought was considered measures of successful transition. And the very first one is not allowing your patient to be lost to follow-up. So I guess everybody agrees that making it to the first visit and continue with your adult provider is an important measure of success. That's both on a personal level and for your entire program, the percentage of your patients that make it to adult care. And if you click on the next slide, and then in a very recent paper published this year in JAMA Pediatrics was a survey of the providers that use the Delphi methodology that really highlights the importance of quality of life as one of the most important factors, important factor on a personal level of successful transition. And that can also be used for your program if you collect a quality of life quantitatively, so you can track that prospectively to show if the quality of life remained the same, went up or went down from pediatric to adult care. Next slide. And this is what we have been using as one of the measures of, one of the metrics from our program. When we started this program in 2007, our patients were getting lost very frequently. If you click the next button, this is the beginning of our program. And then if you look prospectively, last year, we had the highest rate of placement in adult care. 93% of our patients successfully found adult care. Next slide. And then the last step of transition to adult care is after you become an adult and you actually make it to adult care, what, right? So then we've been thinking about this issue a lot, and in 2012 we start partnering with the Methodist University Hospital, which is an adult hospital in town. So next slide. And we implemented what we call the transition clinic for young adults in this adult program. And that has a lot to do with Dr. Tepper was mentioning, you don't really have full brain development until the age of 25. And we see that on a day-to-day. So we decided to have a clinic especially for those young adults who are not fully developed yet. And then we created this element that we thought was innovative at the time called co-location of providers, in which we had an adult physician and a pediatric physician together seeing the same patients, and a nurse who was both a pediatric and an adult nurse. So the nurse was not co-located, the physicians were. The nurse was a hybrid pediatric adult, so she's 50% adult, 50% pediatric. So this program did a lot of good things, and our patients remain in the program more often than many colleagues tell me that the attrition rate in this clinic is under 10%, so it's very good. And on the next slide, it shows what this clinic has done for healthcare utilization. If you remember one of the first slides that I talked about published literature in the young adults that they use the emergency department, they admitted a lot. When we compare our results with the results of published literature, they're better off. They're not admitted as much. They don't use the emergency department as much. So we're happy about that. On the next slide. And what I think having a good transition program, besides really ensuring that your patients become adults and they're prepared and they make it to adult care and they stay with the provider, is that it really as a program allows you to then layer research on it. So if you have a transition to adult program that actually ensures that your patients transition to adult care, remain in adult care, they are in the system, they don't abandon care, then you can do things like having a natural history study, which is exactly what we did. If you click next twice, it shows that a natural history study is important because as the patients become adults and you don't understand risk prediction, studying them as they go from pediatric to adult care, then now you can do things like what are the biomarkers that I should look as a child to predict a bad outcome when this child becomes adult, and then I can implement new treatments and go back and modify the pediatric care. So it's really a circular process. You can only do that if you have a good handle of your population and they don't get lost, don't abandon care. So on the next slide, if you want to know more about the natural history study that we're doing, this is registered in clinicaltrials.gov, but we really established a longitudinal cohort study that is just exactly layered on top of clinical care. So you cannot do good research if you don't provide good care, and that's our motto. Next slide. All the material that we developed for education in clinic is available free of charge on our website, SiNERGe.org. And also for more tools on transition, I recommend you visiting the guttransition.org website and also the HRSA website. The sickle cell niche care website also has a lot of information about transition for sickle cell disease. Next slide. So in conclusion, the survival for sickle cell disease is increasing. Many more adults are being introduced to the, many young adults are being introduced to the adult care. Careful development programs is very important to accommodate this growing population, and having a good functional transition program allows really good longitudinal research. So thank you. And the next slide is just a picture of some of the members of our Transition to Adult Care program. Thank you.
Thank you very, very much, Dr. Hankins. And we'll now open it up to question and answer. If you can type in, there is a chat selection on your computer screen. If you can click on that and type in your questions, we'll be happy to have the presenters answer questions. And we'll just see if some questions come in. Okay, someone has asked if we can make the slides available. So Dr. Tepper and Dr. Hankins, would you be willing? A lot of times what we'll do is we'll convert the slides into a PDF, uneditable version.
Absolutely, that's fine.
Yes, it's fine with me too.
Very good. Well, we will make those available. Anyone that is interested, please just send me an email. And I see the person that has typed in their question. I'll make sure that you get the slides hopefully later today. Other questions? Someone asks, what are sources of funding for the transition program?
That's a good question. So initially when we started, we had a HRSA grant that funded the nurse coordinator. And when I was about to run out of that grant, I went to my administrators and I said, look, I showed the data on healthcare, the healthcare utilization, ED visits and admissions, and the attrition rate in the clinic, and the hydroxyurea utilization, immunization rates. And I said, look, this person is funded by this grant. I'm going to run out of this grant. I won't be able to renew it. And if this person disappears, guess what's going to happen to your program? It's not going to be good. And both institutions agreed to cost share the salary of that person. So that's one. So today, I have a lot of buy-in from both the adult and the pediatric institutions. I think the key is show the benefit to them. They see dollar signs, so you have to talk in their language.
And Dr. Tepper, do you have...
Well, we're quite fortunate to have funding from the state of Maryland through the Department of Health and Mental Hygiene through a special program to also be able to fund a transition coordinator. It's very hard because these services are not billable to health insurance, so that, you know, looking for sustainable ways to support the programs. I think what Dr. Hankins said is the most logical, is to be able to show efficacy, you know, and success for the transitional, you know, for post-transition care, and, you know, then to work with administrators. But we've also, you know, been fortunate in being able to, you know, receive some funding to be able to support the program that way.
And at this moment, I don't have any additional questions up. Let's see. Okay, we do. Is your transition readiness assessment performed at every visit, or
No, it's not. And you don't want to do that. You don't want to do that close together. I think the website gottransition.org recommends you start at 14, and then I guess 14 and 16 and 18. So 2 or 3 times during the adolescent years.
Mm-hmm. So the person goes on to say, is it a minimum of a year, every 6 months, etc.? So I believe you've answered that question. And then the other question is, what are the quality of life indicators used in relation to transition?
There's not a quality of life measure of transition by itself. You can use TRAC, which is a measure of readiness to, but also of learned skills. And that's developed by the University of Florida. But I really think if you want to measure quality of life, you just use a quality of life measure such as PEDS quality of life, the sickle cell module, I think is really good. Or you can use the NIH developed measure, gosh, what is it called? The quality of life measure from the NIH developed. I'm gonna remember in a little bit, but I would just recommend using validated quality of life questionnaires or instruments.
Okay, and then someone has just written in that they missed the response about the funding for the transition program. Is there something available for the Hampton Roads, Virginia area?
I only know about funding from the state of Maryland, so I'm not able to answer that.
Yeah, I'm not either.
Okay.
I'm sorry.
And that's something that I might be able to look into and follow up with our presenters. But I'm familiar with the person that has written in the question, and so I will respond to her directly. Any other questions? Well, then I guess I'll go on with the conclusion. I just want to thank you both very, very much for being with us today. In conclusion, I want to thank our speakers for their wonderful presentations and sharing both their expertise and experience with us to gain a better understanding of the complexities of the transition from, okay, one more quick question. How big is the transition program? We'll interrupt momentarily.
Dr. Tappers or mine?
Maybe you can both just speak quickly to the actual numbers.
So I think you have, at a minimum, you need a nurse coordinator, or it can be a social worker who is the coordinator. So you need a coordinator for the program, a transition coordinator. And then I would say having a psychologist in the group is extremely important if you can have one. So then you need a physician, and probably you also need a physician extender, like a nurse practitioner or a PA.
And Dr. Tepper, did you have anything you wanted to add?
Yeah, well, our program is really nested within each of the subspecialties because we're sort of providing care to all of the specialty providers at Maryland. So our transition coordinator is fortunate to be a master's prepared psychologist so that she has mental health training so she can function in both roles. And then in each of the clinical settings, nurse practitioners, physicians, social workers, and others, on the teams within the subspecialty programs, work with the families. So we really only are supporting the transition coordinator, and then we're working with the rest of the team. So we've been able to, sort of capitalize both parts.
Okay, great. Then again, I will conclude today's session, and we won't take any more questions. If you do want to write in anything more, please do, and I will make sure that those questions get answered via email after this session. So I was just saying that how much we appreciated the expertise and experience that we got to gain a better understanding of the complexities of transition from adolescent to adult care with sickle cell disease and approaches for improving that transition. It's clear that more must be done to improve strategies to help young people as they navigate what can be a difficult transition in order to improve the quality of life and health outcomes for them and their families, as Dr. Hankins' program illustrates. In our next session, we will look at other successful sickle cell disease patient transition to adult care programs. I also want to thank all of those who joined us today for their interest and commitment to the cause, as well as their thoughtful questions and comments. Please feel free to contact me for any further information or contact information related to the webinar or any other topic of interest. We have recorded our session today, and we will make it available to all as soon as possible. We'll also circulate a very brief survey, 6 to 7 questions, that we'll ask you to take a moment to complete. It's a great tool as we move the series forward. Again, thanks so much for being a part of today's webinar. We look forward to staying connected with you all and continuing in our commitment to the entire sickle cell community. Thanks so much, and goodbye for today.